Same disclosures. So we will talk about a variety of issues: your setting, your structure, pathways, improvement activities, performance metrics, and patient and family-centered care, since these are hot topics. Now, you may be in one of these settings. You may work in more than one of these settings, but the administrative issues will span everything from the university to a federal, which is often equated with a resource-poor environment, or maybe an austere one, but also disaster response. How many people are registered for disaster responses? Yes. So these are things that will be deployable and translatable to that setting as well. One of the things you need to think about from an administrative standpoint is, do you have enough beds? And this is looking at critical care bed growth, ICU bed growth, 15%, average number of beds, some places contracted by 3, some added 51, but an average of 16% increase in beds per 100,000 patient population went up by about 0.9. Now, when you look at the bed change, there are some that had negative growth, some that had unchanged or moderate, and some that had high growth, but these were not symmetric. Only a quarter of the regions had more than 3/4 of all of the changes in beds. And when you ask the question, how is that deployed? The top graph has ICU bed expansion as a proportion of population change, and that is for the adult population. And it seems pretty linear. If you now parse that by the elderly, now the beds are vastly asymmetric. You have out of proportion growth with regard to your geriatric patient population. Now, how you deal with that depends upon what you have available to you. Everything from resources to your staffing to the experience level, and this will become important not so much of your physicians but of your support staff, consultants that you do or don't have available, the expectations of performance for your ICU, and may hinge most notably on the amount and intensity of your administrative support. Regardless of what structure you have, surgical ICUs tend to be more collaborative, neither entirely open nor entirely closed. We don't like to let go of our patients. But when you want to modify practice in any of those environments, you need data on safety, the efficacy of what you deploy, and whether or not you're efficient at deploying that therapy at all. And this is this is derived from a 2-part article published in Critical Care Medicine by Art St. Andre, and I encourage you all to read this. It is very, very well done. You can tell Joe that I was plugging the journal. Now, how you get your providers to work in this way and have them embrace a service philosophy hinges on continuity. So you're doing the same thing in a consistent fashion across long time spans, and you communicate. So these 3 C's, if you will, help engender a service philosophy amongst all. Now, the person who leads may have many different defining characteristics, but probably at the top of this heap is the ability to listen. Closely following that is the desire to and the engagement in seeking additional education. You will find all of these other ones. If you think about the person who guides your ICU or someone who's guided an ICU well, you will find many of these, not just one, not just 2. So from a professional development standpoint, these are things on which advancement may hinge. Now, does the volume of your place matter? So if you look at the hospital volume of ICU patients, either low, intermediate, or high, and you look at the odds ratio of a bad outcome, clearly high volume places can have an impact on outcome. This is not new data. We find this for Whipples and other kinds of procedures. The question is, what underpins that? Is it the intensivist? Well, if we're there 24/7, we cost a lot. We provide level 1 supervision for interns if you have interns in your ICU. But the most common is you're there for 12 and you're available as needed, or maybe you're there for 10 and available as needed. Costs less, doesn't change your outcome in any study, and may in fact reduce burnout. So from an administrative leadership standpoint, you need to answer the question, are my providers having burnout? And if so, how do I mitigate against that? Some of your support may contribute to burnout. If you have fellows or residents, there's increased variation in care, that's for sure. You may have much more of an education rather than a process focus to your daily rounds, but they are somewhat more operative independent. Advanced practice providers, much more consistent. If you want compliance with your care pathways, this is a way to do it and do it well. Your focus then becomes much more on care. They have procedural but not operative independence. So if you have a fellow who can reopen the belly at the bedside, in general, your advanced practice provider is not doing that independently. Now, how do we do versus the rest of the world? That's what ROW stands for here. Snapshot of care. 1265 ICUs, 75 countries, 14,000 patients. And when you look at North America in red versus the rest of the world in blue, we are more likely to have our ICUs in a university setting with a higher volume of patients that come through there, more ICUs that are dedicated to be surgical in nature, but not so much difference in the nurse-to-patient staffing ratios during the day or the night. When you look at what impacts mortality, there are a couple things. And so the odds ratio above 1 is not so good. Odds ratio under 1 is much better. Being in a medical ICU, being in a mixed ICU, this is for surgical patients, mind you. And certain nurse-to-patient ratios, if you're getting closer to 2 to 1, that seems to impact mortality. Having an in-house intensivist didn't reach statistical significance in terms of changing the outcome. So, first question, which of the following best characterizes U.S. ICU beds? A variety of increases or decreases or things that are the same. And we have a predominance in 1, overall linear increase, proportional increase, disproportionate decrease, net asymmetric increase, similar changes to bed volume in Europe. And in fact, overall linear increase in total U.S. beds. Remember, the asymmetric increase, the nonlinear increase, was just when you parsed it by the elderly. So the data stacks up. There's lots of data about how your ICU functions, but unit designation matters. And here we're going to talk a bit about staffing. This is one place could put patients in a trauma ICU or a different ICU, same providers, different nursing staff. And when you look at the dedicated trauma ICU in blue versus the mixed ICU in green, outcomes were much worse when they were not in the trauma ICU. Now, this is despite the trauma ICU having older patients with more comorbidity. That's the Charlson Comorbidity Index, CCI, a higher ISS, but a major factor was that the nurses that were there had been there in a stable fashion for more than 2 years. This data spans 5 years. And in fact, when you look at the adjusted odds ratio for any complication, failure to rescue, or mortality, was always better when you had a stable group of nursing providers because it was the same doctors in both units. So something to be said for you from an administrative standpoint to look at nursing turnover as an indicator of success and quality. Now, there's been a lot of talk about electronic health records. You probably have been victim to the Epic deployment in an Epic fashion. And what does that really do for you? Well, it makes it clear and legible. You can't find the story in the chart, but it doesn't really change your length of stay. It doesn't change the cost. But combining clinical decision support with sniffer algorithms to look for groupings of things that are danger signals can result in a 14% mortality reduction. So you can leverage it. It's not just a legible way of putting down your notes. Now, the ICU is replete with conflict, and there are different kinds of behaviors that occur when there are conflict. Now, there are maladaptive behaviors. You might have heard of some of these. I'm sure nobody in the room is engaged in any of them. Fighting, withdrawing, not for the two of us alone. Doctors tend to engage in these behaviors in a variety of studies. We tend to be more detached, while nurses tend to be more emotionally invested in the conflict, and they tend to be constructive. They vent. This is a constructive behavior, not a maladaptive one. They engage mentoring networks. They work towards team cohesion. So support of engaging in constructive behaviors may be a target for the ICU administrator because conflicts go through a variety of phases. Latent conflicts finally emerge. They can escalate. This is where you should de-escalate. We try to de-escalate by negotiating, and if we do that, we have successful resolution, but if we fail, it can in fact recur. The trajectory that you'd like for the conflict is not avoidance or denial, it's not one side giving in, it's not aggressive competition. We see this quite commonly between teams and with end-of-life discussions, but shared accommodation, reaching a solution that both sides can live with. And that takes skill. Many of the things that underpin these are fear, guilt, bias, the kind of information they've had. Remember, think back to that communication slide from the prior talk. There are preconceived notions of what should happen, less so finances, but it provides you with an opportunity to repair it. And we often repair this in a couple of different fashions. One is to gauge a clinical ethics consultation. Problem is, you don't necessarily have an ethical question for them to answer. So what has become popular is the incorporation of a palliative care team as part of your ICU stable of individuals to aid in and to perhaps head off conflict. They are very good at helping establish goals of care, end-of-life discussions, soothing emotional discord, and they may be reliably deployed for patients that have recurrent high-intensity care, such as those in the prior Harvard study. The problem is, if the family is not ready to listen to what do we do at the end of care and what do we do to palliate our existing situation, they may not respond well to the palliative care team, and therefore a dedicated conflict management team, and you need to train providers for this, that are not invested in the care, but they're invested in having a resolution, is much more commonly being deployed at this point in time. All of us can be trained for this. Lawyers, police officers are commonly trained in these conflict management techniques. Question 2, conflict in the ICU. Infrequent, end of life, adaptive MD behavior, give it to the ethics committee, or frequently arrest following the latent stage. Yes, in fact, it most often centers around end-of-life issues. That is for sure. That is the one thing that tugs against everybody. The team, the nurses, the family, other consultants. So peg it on end-of-life discussions. Now, what do we do with ID consultants? Because there's often conflict with the ID consultant. This is one study, and it's parsed by, I couldn't resist. So parsed by who had an ID consultant and who did not. Let's look at what they did. Now, I will call your attention to this metric right here. Surgical or interventional source control, recommended in about a quarter of the cases. Okay? And you can see all the other things that are identified in terms of antibiotic changes, but source control being recommended is an important one. And when you look at the outcome of it, now the solid blue line is ID consultation discharged alive. And this is days after the blood culture was collected. Not positive, but after collected. So there's an improvement in outcome with ID consultation. And of course, fewer people, if they've had ID consultation, then die. That's the dashed line, so they're mirror images of one another. So there's value in engaging the consultant. And this will lead right into prevention of complications. And so there are many ways to do this. There are collaborative teams, checklists, bundles, a safety officer, and the use of a database. And there are some additional slides in there about whether it should be your homegrown database, a commercially available database, or some hybrid of the two. But you do need to have a focus on safety, and you need to be conversant with the safety metrics as your ICU administrator. One of them is delirium, highly investigated, clearly aggravated by therapeutic agents, analgesics, and sedative hypnotics seem to be reduced with typical or atypical antipsychotics depending upon what you have on your formulary and you can use, and there will be an overlap with the post-intensive care syndrome that we'll talk briefly about. Many risk factors. Strongly correlates with multiple meds, strongly correlates with benzodiazepine dose. And you'll find that the proportion that are intubated over time is much higher, the solid line, for those that have had delirium. If you look in an orthopedic group of patients, and this was recently published in CCM, the two sets of lines here, The higher line is the impact of delirium with different groups of patients. So delirium always adds a negative impact on your ventilator length of stay, and therefore your ventilator-associated condition and ventilator-associated infections. How about distance? So if you look at the home unit and you compare the patients in the home unit to boarding in another unit on the same floor versus boarding in a different unit on a different floor, what happens? Because it happens all the time, right? And where do you round first? Do you round first in the other unit? Do you round first in your home unit? So delirium correlates with distance. And so you can see here in the far bar, if you are 339 feet away from the home unit, you're much more likely to be delirious. That is the different unit, different floor. And in fact, when you look at pneumonia rates, these are the outliers in green versus the home unit in blue. Pneumonia is higher. The odds ratio for pneumonia is higher. VAP odds ratio is higher. Delirium and its odds ratio are all higher, presumably because your team is not there. So you need to have some mechanism to deal with patients that are outliers and not just the ones in your unit. This is also incumbent upon you from an administrative standpoint. So question 3, delirium is least strongly associated with benzodiazepine, boarding in a remote ICU, the type of operation, physical restraint, and changes in the environment of care. Excellent. Doesn't matter which operation you do, all of the others have an impact on delirium in terms of changing perception or ability to perceive things or how the environment has shaped that individual's existence at that particular point in time. Lessons from Ebola. There's only one slide on this, don't worry. Having lived through this, a predetermined protocol, a planning phase, a dry run phase, and a wet phase so that you simulate everything, even for the cleaning person, what to do with the spill. Managing waste removal with separate drains in an appropriate location for it. How you manage life-threatening events is important because the teams that volunteer for this may not be the same teams that work together on a daily basis, and therefore they don't have the transactive memory, that cohesiveness, that expectation, that understanding that everyone will do exactly which job when, that may be lost. How you schedule your intensivists, the nurses, the RTs, all of this has to be carefully taken into consideration, and you may need to plan for twice the amount of time as usual. And of course, this is best deployed in designated facilities. There are all kinds of slides about how you arrange your particular unit that are also included in this packet. You have to decide whether the reward outweighs the risk for these. Technology, important technology notes. IO lines are just as good as CVP lines for emergency care. They are now part of many facilities' code carts and emergency response teams. You may not be using high-flow nasal cannula O2 as an adjunct to maintain oxygenation while you are intubating your patient, but that works well too. And for trainees that are intubating, a glide scope is invaluable in increasing the likelihood of first-time oral endotracheal tube placement. And no, there still isn't a single best monitor, despite anyone visiting you and touting their goods. But you have to train people to do this. So crew resource management training is important. This is an approach that shapes a culture of safety that allows everyone to speak up and, in essence, from a Toyota point of view, to stop the line when there's a problem. The desired end goal of this is a modification of behavior in an adaptive fashion. Now, there are organizational, team, and individual crew resource management training motifs, but all of them are able to take some intervention, and you can see this here, some intervention that has fidelity, it's reproducible, and if you're looking at management process, these are latent errors. They're hiding under the rug, so to speak. They're waiting to occur if you engage that process. But very specific interventions can be tied to clinical processes that really are active error management, and those are very nicely tied to patient outcomes. There's a lot of literature about the value of crew resource management training. Now, part of that training can be to help mitigate against the post-intensive care syndrome. Now, you have identified these kinds of things in your patients: weakness, cognitive dysfunction, some psychosocial dysfunction, and even deranged family dynamics during the hospitalization and perhaps afterwards. And it all falls under this rubric of post-intensive care syndrome. And the reason that it's here in administration is that the outreach for outcomes from your ICU is also part of your administrative domain. Figure out how did they do afterwards. And so the cognitive domains in this syndrome that get impacted, if you're going to query them, are really memory and executive function. My wife accuses me of having defects in both of those. These are the at least currently identified risk factors, and at the center of this is delirium. So again, this is a hammer-home message here. But immobility, sepsis, heavy sedation, and symptomatic hypoglycemia, as well as episodes of hypoxia, are equally important. Now, the effects of the post-intensive care syndrome include not just the patient but the family, and have been durably identified to decrease the quality of life, just like having an open abdomen. Financial hardship is enormous. Family savings get wiped out. Many of the patients that have post-intensive care syndrome, this is more than a quarter, don't return to work, and as a result, the caregiver who needs to provide their care also doesn't go back to work. And much of this centers around an appropriate care event not being appropriately interpreted and incorporated as an abnormal and intrusive memory. And if you carefully question patients that have spent 2 weeks or more in an ICU, 88% of them will meet some criteria for post-traumatic stress disorder. That's a staggering amount. There is, of course, a kindergarten-based mitigation strategy, A, B, C's, D's, and E's. We think these work. We're not entirely sure, but they certainly make sense, and they integrate with the physiology. But this is the piece that you need to keep in mind, is that the patient that comes to your ICU that sees you and gets really good care often doesn't see you when they're done. They see their primary care doc. And so this is really a failure to detect rather than a failure to rescue, because we've also failed to mitigate. So on discharge, they don't see an intensivist except for those people who do trauma and acute care surgery. We still see them back. And I'll bet, as part of your ICU administrative metric, you can readily incorporate a tool to ask and answer this question for your follow-up. Choosing Wisely campaign, which had representation from SCCM, has admonished us for things that we should not do. This is the structure. Routinely order lab tests at regular intervals. Instead, order them on demand. Transfuse packed cells without bleeding for people with a hemoglobin above 7. Use TPN in nutritionally replete patients earlier than 7 days of their ICU admission. Don't deeply sedate those on ventilation without very specific indications for doing so and without providing a spontaneous awakening trial. And don't continue life support for patients that are likely to die or have significant functional impairment without offering comfort care. And so we'll conclude. We've made up a little bit of time. ICU administration has multiple aspects. You've gotten the highlights. You have much more in your slide set. There are some very common areas that you can take, and they'll be portable with you. There's not a lot of controversy here, but it's just a little bit. You can put your own spin on it. So with that, I'll be happy to take any questions.